do, that is the treatment of CRPS. So first you have to diagnose the case of CRPS, then only you can go for the treatment. So my slides are full screen visible, isn't it?
Yes, sir.
Okay. So let us see that what is CRPS. Here, first I show you some pictures. So see, this is the hand and foot pictures. So do you see any difference? So here the hand skin looks normal, but here you see it is a bit dried up skin. So both the hands are not same. Okay, color difference is there, skin texture difference is there. And of course the nails are also a bit I mean, you can see the nails here but not in this side. Here in the leg also you see there are some difference. This is a bit bluish discoloration is there. Okay, and of course from the picture you cannot see anything more, so you can understand that there is a difference. One looks normal and one looks abnormal. Okay, here also in the feet you see there is mild swelling is also there. This is of course objective swelling we can see, but sometimes patient can come with subjective swelling. Only patient will say that patient can identify the swelling, but we may not perceive that way. So and you see the color difference. Okay, so in this type of patients, if comes to you, then and with a typical burning pain, most of the time these patients come with a typical burning pain, even they will not allow you to touch, and extremities are mainly affected, though there are cases where other symptoms are there and extremities are not affected, other areas are also affected, but commonest presentation is the presentation in the extremities, so either hand or the feet. So if we consider the symptoms or signs which they will come to you, then we can divide the symptom signs in 4 parts. One is sensory, one is motor, one is pseudomotor, one is vasomotor. So gradually I will tell what are the signs and symptoms come under this category. Now first thing is sensory symptom. Only one sensory symptom, you understand that patient will come with tremendous severe pain, and in CRPS most of the time that you will not see any reason of the severe pain, but patient will have severe pain, and it is a burning type of pain, and it is a neuropathic pain. This is not a nociceptive pain. Already we have taken class about the nociceptive and neuropathic. In neuropathic pain, it is a pathological pain. It is a it doesn't serve any physiological purpose. Okay, so there is no good reason why the patient is crying with pain. So that is first thing is sensory. In sensory, symptom is pain and type of pain is neuropathic. Okay, motor part. In motor part, most of the time patient is not using that part due to pain. Neither patient himself or herself will touch that area, nor patient will allow you to touch. So ultimately there will be disuse atrophy. Here in these pictures you will not find disuse atrophy, but disuse atrophy if it continues for a long time and the treatment doesn't give much relief, then patient will develop disuse atrophy. So that is one motor symptom under the motor category. Then vasomotor and pseudomotor. Pseudomotor means there is a sweating abnormality. Either it is sweating is too much less, or it can be more also. Sweating is in there in one side, and vasomotor. Now it is see color discoloration. Either it is bluish discoloration or reddish coloration. If this is normal, this is abnormal. Okay, this is reddish coloration and this is bluish discoloration. Okay, so this color changes. Now you see in sensory symptom, when this patient is coming, as soon as the patient comes in this type of presentation, first we will try to see for any patient, actually we will try to see that which type of patient is having. So So for confirming that it is not a nociceptive pain, it is a neuropathic pain, first two symptoms are very important. That is, one is allodynia and one is hyperalgesia. So allodynia means pain to touch. It means whichever some stimuli which doesn't give any pain, that also patient is getting pain. So this allodynia, even if you touch slowly, patient will get pain. And hyperalgesia to pinprick. So this one actually we do not do not test on the patient, but allodynia we will test on the patient. That just mild touch also patient will have too much pain. Then vasomotor, so temperature asymmetry and skin color changes. So this is actually due to the blood supply. So if there is too much blood supply, it will be pink coloration, discoloration, as I showed you the picture, and there will be increased temperature also. And if there is blood circulation has become less, then it will become bluish discoloration and skin color also goes down. Okay, then pseudomotor, so edema or sweating changes, both this comes under pseudomotor changes. So here, as I told you, edema is not always clearly seen by us, but patient will say that it is swollen, and sometimes it is very evident. And sweating, it can be more or less, both is possible. And these pseudomotor changes, what they also tell us something about that. So not only pseudomotor, vasomotor, both, that it has this type of pain has a sympathetic disturbance. Though this is also a neuropathic pain, without sympathetic disturbance also patient can have neuropathic pain, but with sympathetic disturbance also patient can have neuropathic pain. So all these symptoms gives us a direction that in which way to think. First, we have understood that it is a neuropathic pain, and second, if we see the vasomotor and pseudomotor disturbance, then we know then that sympathetically maintained pain. This is sympathetically maintained pain, that nerves are causing the pain, but it is not only the somatic nervous system, it is the sympathetic nervous system which is mainly responsible. Then comes motor and trophic. So as I told you, that if you don't use a hand or any muscle for a long time, either hand or feet, then a patient may get these trophic changes. And of course, there are some hair, nail, skin. So all the changes are possible in these areas also, trophic changes, and patient will develop weakness, tremor, and dystonia. Though dystonia is a completely different diagnosis. Neurologists diagnose dystonia, and then treatment is different. But then this also possible with CRPS. Okay, this is a differential diagnosis also, and this is possible with CRPS also. So you see this patient. So this patient came to me long back. So this is only a 16 years old boy. So there is no such reason that we will tell or anyone will say that this is a psychiatric patient. But when he consulted 16 doctors, and he was given even a diagnosis of somatoform disorder, and then many other diagnoses was given. But actually these diagnoses were given because CRPS diagnosis was not very common, commonly known to all, or commonly treated by everyone. This CRPS, even the nomenclatures are new, and being treated by mainly pain physicians, and of course seen by neurologists also. So others, when they with the symptoms, so symptom was what? So here you see this is a glistening skin, and as such there is no swelling, but patient said me that there is a swelling. And then so glistening skin is also very common. And second thing, this is actually by in picture you may not understand that this is a dirty hand. Patient did not even allow anyone to touch, or he did not wash the hand for nearly 1 month, 1 or 2 months actually. So it became very dirty, and he will always sit like that, and he will not allow anyone to touch, and there was tremendous amount of allodynia. So here all hematological, serological, and radiological investigations were done, which were normal. NCB was advised by many doctors without considering that how someone can do NCB in this patient due to severe pain. So NCB was not done. And of course, this much was clear that it is a neuropathic pain. So under neurologists, he got different anti-neuropathic pain treatments, but effect was very less. Even he was given a high dose of amitriptyline also, but then it did not give relief. So here, as I told you, when patient comes, you should go, we should first distinguish that it is a nociceptive and neuropathic pain. So these are the differences you already know. For neuropathic pain, it is a shock-like tingling, burning, this type of pain. Okay, and nociceptive is a well-localized pain. It is coming from a structure, either from a joint or from a tendon. So it is always localized, and you know the structure which is causing the pain, and usually time limited. Nociceptive pain usually decreases over time, and whereas nociceptive neuropathic pain, with time it will increase. And generally responds to conventional analgesics. Neuropathic pain doesn't respond with conventional analgesic. Okay, but then directly, just by seeing the pain, patient and type of pain, you should not immediately jump to the diagnosis of CRPS. Why? We have to rule out uh, all the different differential diagnosis, because differential making the this is the exclusion diagnosis, because differential, most of the differential diagnosis have a evidence-based treatment policies. So if we can diagnose, we can put the patient under a specific differential diagnosis, then patient will get a what should I say, not a broad treatment, but a specific treatment for that diagnosis. So CRPS should be an exclusion diagnosis when we cannot prove any other diagnosis by that. So see, radiculopathy, plexopathy, neuropathy, so all these things can be a differential diagnosis, because these are all also coming from the nerve, but these have some specific reasons and specific treatment. Like commonly, if it is a bit older individual, diabetic neuropathy remains a major differential diagnosis. You should not immediately say that it is a CRPS. So, and then mainly the neuropathic, different neuropathic painful conditions, they are the differential diagnosis. Then comes work. And another thing, though I will tell later, that while taking the history, I'm proving that it is a neuropathic pain. So, allodynia, hyperalgesia, I will search for. I will take the history also by asking that whether it started after any injury, any precipitating event. Most of the time, it is, if it is the hand or feet, it presented in the hand and feet. So there can be a fracture, or can be a stroke, severe episode of CVA, ischemic CVA or hemorrhagic CVA, whatever. But then this type of event are commonly related to this CRPS patients, like wrist fracture, ankle fracture, they are very commonly associated with CRPS. So in workup, as I told you, workup, we don't have any workup to prove. Of course, there are some experimental workups which can prove that, okay, this is a neuropathic pain and coming from maybe this is a CRPS. But commonly in clinical practice, the investigations what we do, that is actually to exclude to exclude the important differential diagnosis. So blood test, NCV I have written, but NCV most of the time it cannot be done. But if can be done in some low intensity pain, if in some patients, so you can write vascular studies. So, and then plain radiographs can be done. Here, one important thing is, in plain radiograph, what you want to know, as I told you, it is sometimes related with previous fracture. So you can see that whether previous fracture has, though it is not our part, orthopedician will see, but then still you can do an X-ray to see that previous fracture has, if there is any malunion, disunion, those type of things, because they can indicate to a nociceptive pain. Okay, and other thing which gives say some positive clue towards CRPS, that is resorption of subperiosteal and trabecular bone, and actually localized osteoporosis. Okay, localized bone demineralization and or osteoporosis. This localized osteoporosis has been related to the CRPS. I mean, there are multiple evidences. So with X-ray, I want to see if there is a history of fracture. I want to see that part, and I want to see if I can get a positive indication that it may be a CRPS. But don't think that if osteoporosis is not there, it cannot be CRPS, because this is not a diagnostic criteria. And then 3-phase bone scintigraphy. So this is also a investigation which gives a positive clue towards CRPS, but it is also not done, I mean, in every patient, but it can give more uptake in the CRPS area. Okay, then comes MRI. So MRI also, this osteoporosis and all can be seen. Then other things in experimental setups like QST, qualitative sensory testing, autonomic function testing, and biopsy. Biopsy, of course, not done, but then these can be done in a experimental setting to see a positive clue, to get a positive clue towards CRPS. So remember, in an experiment setting, you can go for those investigations which give you a positive clue towards the diagnosis, and in clinical practice, you all do all the investigations which just rule out the differential diagnosis. Okay, then diagnosis of CRPS, as I told, mainly based on history and physical exam, nothing else. So what is the history? Mainly history of a trauma precipitating event. And what is the physical examination? Mainly the allodynia hyperalgesia. Investigations are adjuncts, rule out differential diagnosis. So these three things are very important. Now IASP, which is a major organization for all pain physicians, so they first in 1994 gave the consensus criteria that which patients we will include under the CRPS, because earlier than that, before that CRPS had not less than 20 names in different parts of the world. Someone will say this, someone will say that, different I mean, there are multiple names are there. Then other criteria was also there, but then ISP criteria, and now this is the time of Budapest criteria. So these criteria till we are using for diagnosing. So here already you know the 4 divisions. So these are signs and as well as symptoms. In these 4 divisions, we will consider the signs and symptoms. And to make a diagnosis, we will have patient has continuing pain that is disproportionate to any inciting event. So that is necessary for any neuropathic pain. This is always found. There is inciting event is now healed, say after fracture, it is healed, so, but then pain is continuing. Then patient has at least this, so this is important, 1 sign in 2 or more category, and third is 1 symptom in 3 or more category. Okay, so these are the categories: 1 sign in 2 or more category, and 1 symptom in 3 or more category. And no other diagnosis can better explain the sign symptom. So ruling out differential diagnosis. So I will say that there is hardly any reason to memorize all these things. Just remember that when patient comes, we will look for some positive points, and we will rule out all differential diagnosis. That's it. Because positive points, number of more positive points will give you more surety that it is CRPS. But if it is less, then also, if you have ruled out all the differential diagnosis, then also you have to consider that as CRPS. So that I am coming now. So ISP, as I told you, in 1994 when they renamed, so they took mainly two names. One is reflex sympathetic dystrophy, one is causalgia. So they told reflex sympathetic dystrophy as CRPS1 and causalgia as CRPS2. So all are basically CRPS. These are all names of CRPS only, nothing else. But these 2 names were more in you can say more in use globally, but there were at least 20 names. So you see, CRPS presentation, I showed you some pictures. So see some other more pictures. So here, see this patient came. Hardly you can say that what is the problem. There is no, not much color change. Though there is some, I mean, glistening skin in one side. So this side is a bit, it looks that a bit glistening skin is there. But actually, patients, while seeing, I could not find much of any difference in the this both hands. But patient has burning pain and patient has allodynia. So patient came with only two symptom, not two symptom, sensory symptom, only sensory symptom. Motor part is also there. Like patient did not use the affected limb. The affected limb patient did not use. That's it. Vasomotor, pseudomotor was not there. Now this patient, in this stage, so this is a pinkish discoloration, and you can see the edema is also there. So this is very clear that okay, there is something wrong is going on. Here it is not clear that something wrong is going on. Only to one symptom patient is saying. Here you can see these two pictures, you know that all the things are wrong. Okay, this picture is a late presentation, very late. So how I got the patient? I got the patient in this way. So actually this bandaging is done because somebody in physiotherapy, they tried to forcibly straighten the finger, and they made a fracture of this finger. So this is the condition when the patient arrived, and you can see there is too much of trophic changes and motor, mainly the muscle wasting. So these are all disused muscle wasting. So this was a late case, and this is contracted like this hand, and patient had severe allodynia hyperalgesia was there. So after 1 month of treatment nearly, patient was like this. When patient, I mean, yeah, we prescribed the physiotherapy exercises at home, and patient went home. So patient was like this, and at least pain was much less, and patient was using the hands for small works. So here you can see that CRPS 1 and 2, as I told you, one is causal RSD, and CRPS 1 RSD, and this is causal GS. So why the distinction was made? This distinction was made only for prognostication, and there was no other cause, because the symptoms are same. Symptoms remain same, but then prognostication. So how it has been differentiated? On the basis of precipitating event. So CRPS type 1, actually precipitating event is not there, but in CRPS 2, precipitating event is always there, though they have written that sometimes actually without any detectable nerve injury or precipitating event, just suddenly started. So without any event, CRPS 1, with some event, CRPS 2. So this is just for prognostication, otherwise treatment is same. So what is the prognostication? Here progressive case, CRPS 1, which started just by itself without any reason, so it is progressive. And CRPS 2, which had a reason, so at least some fracture, so it is not that progressive. It goes up to this allodynia hyperalgesia continues, so up to a stage 2 3, maybe 2 or 3 it goes, but not more than that. And here you see in CRPS 1, bone atrophy also is possible. So it progresses. So when patient comes to you, it gives you an option to prognosticate and tell the patient that your CRPS is very severe, or otherwise also. So you can see this is a CRPS 1 patient, and it is so severe. Stages: acute stage, dystrophic stage, atrophic stage. So here main things: acute stage within weeks of injury, and then within months, and then for years. Here the main thing is acute stage, you have already understood. I mean, this is very easy to understand that okay, red, burning, all actually pink is discoloration. You remember acute stage is pink, means everything is more. Okay, there is vasodilation and blood is more, so temperature is high, sweating is more, and so everything is more actually there, and pink discoloration. And dystrophic stage, after within months, what will happen? So blood supply will get decreased. Decreased means it is less than normal, so it will be cool. cool diaphoretic, and then there is atrophy, Sudex atrophy on bone X-ray. So then it becomes actually bluish discoloration. Then in second stage, it is bluish discoloration due to decreased blood supply. And atrophic stage, that is, you can understand that all the muscles are atrophied. Even there will be changes in the nails. There will be hair changes. Here there is falling of hairs. So that is the atrophic stage. CRPS NOS, as I told you, I showed you the first picture that hardly we can understand that there is a problem in this patient. So there also you have to diagnose. If you do not diagnose, we cannot give treatment. So IASP only told that patient should get treatment without a treatment which earlier happened when the nomenclature was not there. So anybody will diagnose anything. I mean, because they don't have a one nomenclature of diagnosis. So there were 20 names. Now we have narrowed down the names. I mean, we have fixed a name, but then criteria is very tough. Criteria is very not that easy to for every patient to fulfill. So if some patient, you can understand by seeing that this is going to be the CRPS case, the symptoms are now starting. We know, say fracture wrist was there, or CVA case. Now just saying that burning pain, and you by outside you cannot see that without pain there is nothing else. So how the patient will get treatment, or you have to wait for those another few months so that other symptoms come and then you treat. So this doesn't happen. So another third category was told that CRPS NOS means not otherwise specified. If you have ruled out all the differential diagnosis, and you see that few symptoms have started of CRPS, means allodynia hyperalgesia has started, then you feel that it is likely to go for the CRPS only, then you can diagnose at a CRPS NOS. As soon as your diagnosis of CRPS comes, treatment of neuropathic pain follows. Okay. And this is for every pain physician. Always make nowadays, of course, AMC, NMC guidelines have come, and that is going to be stricter and stricter. Of course, I understand, because this is true that when you write a prescription, this doesn't should not happen in this way, that patient says pain in hand and then treatment. It should not be like that. Pain in hand, I mean, all doctors. So at least my advice to all pain physicians that please write diagnosis. Please write a broad diagnosis at least. If you cannot make a pinpoint diagnosis, then also broad diagnosis. And then plan of treatment, and then go for treatment. Otherwise, a next person seeing your prescription won't understand anything. So etiology and pathophysiology, I'm not going into it, because CRPS is actually a neuropathic pain. So whatever happens in neuropathic pain, here also it happens. So keyword is sensitization. As already I took the class of sensitization, neuropathic pain, nociceptive pain. So sensitization is the main thing here. Mainly the nervous structure, neural structure is starting the pain. Okay, it is not carrying the pain, it is making the pain. Okay, action potential starts from neural structure. And it, as I told you, from the history itself, we should get a clue that whether it is sympathetically mediated pain or not. So if it is a vasomotor and pseudomotor symptoms are there, then most likely it is a sympathetic pain. And how can you know whether it is sympathetically mediated pain or not? Dr. Kanchan showed you the stellate ganglion block. So stellate ganglion is ultimately acting on the sympathetic system. If patient's pain is relieved with the when you have proved that you have blocked the stellate ganglion correctly. Of course, because after giving injection has gone somewhere else, and patient's stellate ganglion is still not blocked, and you have diagnosed that okay, this patient has not is not sympathetically mediated pain. So this doesn't happen. That should not be. So first you give stellate ganglion block, prove that your stellate ganglion block was correct. Okay, how will you prove? All the temperature will rise, Horner syndrome may come, so those things, and then with positive stellate ganglion block, if you see that pain is also gone, then you know that pain is from sympathetically, this is a sympathetically mediated pain. But if the stellate ganglion block, all the symptoms are there, but pain is not gone, then you know that it is not a sympathetically mediated pain. So new hypothesis. So there are multiple hypotheses. Treatments, there is no detailed treatment is needed here. As I told you that it is the neuropathic pain. So all neuropathic pain treatments are applicable here. So our backbone of treatment is neuropathic pain medicines, tricyclic antidepressants, and anti-epileptic. So tricyclic antidepressants is which medicine? This is the amitriptyline, and then nortriptyline also, amitriptyline, nortriptyline, and anti-epileptics means gabapentin and pregabalin. Okay. Then other drugs are also there, SNRIs, duloxetine and all we can use. And intervention, already I told, sympathetic block, which has been told to you. So management of CRPS, remember the goal of management, it is a multidisciplinary coordinated approach. Because as I showed you the picture, I sent, ultimately I had to send to physiotherapy when the patient comes in a trophic stage. So after pain relief, what will do? Patient will do. Patient have to do some exercises like this, and who will supervise that? So that will be done by physiotherapy. So you have to send to the physiotherapy. So that is one discipline you are adding. And then patient may be very depressed. Patient want to commit suicide. So you have to bring psychiatrist also. So mainly psychiatrists and physiotherapists help is needed for treating CRPS. Functional restoration should be our goal, because only pain relief is not sufficient. That hand also should be useful. So functional restoration should be our goal. And treatment algorithm to normal function, treatment plans tailored to the individual problem. That is true. Every patient doesn't respond to the same treatment. It is very commonly seen. So in some patient you will see that stellate ganglion RF, block you have given, and patient is very happy. And some patient you will see that you thought that your earlier patient had got so good relief, so this patient will also get relief, and this patient may not get any relief. So individually you have to approach. Then comprehensive diagnostic evaluation. Okay, early and aggressive therapeutic intervention, of course. So already I told this. So mainstay of treatment here, sympathetic efferent blockade. Why? Because in pain practice, what we do extra, that is sympathetic efferent blockade. Okay, if it is a not sympathetically dependent pain, of course, then it doesn't become the mainstay of treatment. But luckily, majority of patients get pain relief with sympathetic blocks. Okay. Then, as I told, physiotherapy will add, but vocational rehabilitation, recreational therapy, cognitive behavioral therapy, mirror therapy, all these things have been tried. When all modalities fail, then it is the, what is that? This is the your spinal cord stimulator or intrathecal pump. So these can be put anywhere, wherever it is a severe pain producing entity and nothing is helping. So these has been tried. Though it is a neuropathic pain, so we will go for a neuropathic treatment, neuromodulation. That is the spinal cord stimulation more than the intrathecal pump. So here, in this patient, we were giving continuous stellate ganglion block, continuous. So patient had good relief after patient. This was a admitted case, and patient got the stellate ganglion block with other oral medicine. So many years back. So this patient got good relief. So in this patient, this boy was there. So we did first stellate ganglion block, and then I did RF of stellate ganglion. So this paper is published actually. So what more? People have tried many other things, but everything is not needed. Okay. So there is a concept that CRPS1 is a misdiagnosed form of CRPS2. Means there is no CRPS without injury. There has been any injury, but the nerve concerned is so small that it has not been detected. So there are multiple. So one more important thing, as I told you, you have to give treatment to some to a presenting patient. whether the patient fulfills the whole criteria or not. If it fulfills, then it becomes very easy to write CRPS. Otherwise, we have to write CRPS NOS. Okay, but there are some other type of presentations also, that abdominal wall CRPS. Then lumbar herniated. I mean, like, this is back pain. Even the CRPS of back, abdominal wall. Even in my practice, I have seen thigh CRPS. So these are also possible. So keep in mind that in these patients also, I will treat at least. I will put the query CRPS diagnosis and I will treat. Okay. So current some understanding is it is a small fiber neuropathy. Conclusion. Okay. Anyway. So any question? Anyone has any question? So remember, as soon as you start a pain clinic, you will get surely a CRPS. Why? Because other stream doctors, they are frustrated with this type of patients, and after treating them for some time, they will surely send to you. So you will get this type of patient. So if there is any question, tell me. Otherwise, I will just share the slides of cancer pain. What is this? Screen. Cancer pain. Okay, so this is another topic. This is very important. So always remember, cancer pain you have to treat in many. If you are working in a hospital, if you are working in private, you may not get that much of cancer pain because patients are busy in with the oncologist. At least I'm telling my experience. It is not like that everyone will have the same experience. So, but then if you are working in a hospital, then you will get referral, of course. So in cancer pain, what is our main learning objective? So first thing, see the magnitude of the problem with cancer pain, difficulties in managing cancer pain. So and how to assess a patient in cancer pain, pharmacological management, and steps to perform some of the common interventional management. So here, so these things we will learn. So here, magnitude of the problem. Okay, so this you read from the books. A lot of patients have cancer, and mainly in, say, in India, in my country also, that there are 28% patients only receive pain and palliative care. So here also many very less people only get pain and palliative care treatment. Otherwise, everyone is busy. Even the pain patient also is busy in the oncology treatment only. But and they feel the mainly many this is a conception that okay, cancer patient will get pain, that is normal, but that is not normal. Yeah, we can treat the pain, and patient can get a lot of time of his life, last life, a productive last life, and after that, of course, for last 3 days it is different thing, but then you can treat pain for a long time. So common symptoms in terminal cancer. So these are all common symptoms. You can see pain is the main symptom in 69% of patients. Anorexia, constipation, these are the other symptoms. Constipation, why? Constipation can be due to some cancer also. Constipation is can be there, but otherwise it is the opioid. It is the opioid which gives the constipation symptom. Dry mouth. So dry mouth have multiple causes. Patient is anxious, that is also cause, or tricyclic antidepressants is going on, so that is also a cause. Nausea, vomiting, of course, that is you will get in a lot of patients. Insomnia, dyspepsia, vomiting, edema, cough. So these are also there, but then pain is the main symptom. Remember, common causes of pain in the cancer. Okay, so here you see first thing is malignancy related. Okay, so when we treat a cancer pain patient, we need to know that what can cause the pain. Then treatment becomes a bit easier and targeted. So first thing is malignancy related. It can be a bony metastasis. So bony metastasis pain is a different pain. Okay, it is a typically from one site localized pain. It is a localized pain and severe pain, severe localized pain, bony metastasis, and then soft tissue metastasis that is also possible. Visceral metastasis. So metastasis pain is one type of pain, and metastasis if in brain patient becomes disoriented. So if you see suddenly a patient becomes disoriented, always think that there may be a brain metastasis case. Okay, and then of course many patient can develop just some patient has come to you and saying that abdominal pain is too much. Don't jump on the just think that okay, it is due to the cancer only. It can cause bowel obstruction also someday. I mean, and in other days it is due to the visceral cancer only, but then someday this can also have its effect. Okay, because the opioid causes too much of constipation. So then you have to do something for this also. Then pathologic fracture, hemorrhage into a tumor, tumor related neuropathic pain. So all the cancer related pain is there in one side. Second thing is anti-neoplastic therapies. So side effects from chemotherapy, immunotherapy, hormonal therapy, and radiation therapy. All these therapies can affect the nerves which are just nearby to the cancer lesion. Okay, so these nerves also can get affected during the radiotherapy, and mainly the radiotherapy and chemotherapy, immunotherapy, they cause neural damage in all over the body. So after taking chemotherapy, peripheral neuropathy, patient will say that burning feet and burning hand. So that is very common. Okay, so these therapies also have their action. Other comorbidities which were there for, say, one patient has developed cancer, but patient had severe back pain from earlier time. So that will also you have to take care. Oh, I did not make it full screen. Just a minute. Slideshow. I don't know where it gone. I don't know where it has become the full screen. What has happened? Okay, here. Okay, so okay, so these are the causes. These are the causes in cancer of pain in cancer patients. So mainly due to cancer itself and due to therapy also. In 30% cases, you can say that therapy is causing the pain. Okay. Then while cancer treatment, it should be a socially and economically productive life, our aim of treatment. Okay, and patient compliance of treatment is also is our concern. You are giving a lot of drugs, but patient is so depressed that patient is not compliant, patient doesn't listen to you. So you have to see that area also, and that's why management of cancer pain is said like that. You consider the cancer pain as a total pain. Total pain means it has multiple aspects. It is not only the physical pain, it is the emotional side, emotional pain also. So while treating cancer pain, you have to take care of the emotional side also. Otherwise, patient will not take the drugs. Aim for pain score of less than 4 by 10. Why it is written like that? Because most of the time you cannot get a 0 score. So if it is less than 4 means mild pain, then you have you should think that okay, this much is acceptable, because we have to take care of the side effects also. Side effects should be acceptable. Cancer pain have the most diverse type of pain. So different cancer, as I told you, it can be acute presentation, severe, it can be chronic, dull pain. It can be a breakthrough type of pain. Breakthrough pain means suddenly comes and goes, but then it can be a continuous type of pain also. And it can be nociceptive pain, it can be neuropathic pain, it can be mixed pain. And most of the time we find cancer pain is a mixed pain. Okay, mixed pain, how do we understand? It has some neuropathic pain characters, allodynia, hyperalgesia, mainly allodynia is there sometimes, And why it is nociceptive pain? Pain increases with movement. Okay, both the things patient will say that patient's movement causes increase in pain, but that doesn't mean you will ask that, okay, when you are in rest, then you don't need have any pain. Then patient will say, no, in rest also there is some pain. There is paresthesia going on. There is burning type of pain is going on, but movement increases the pain. That means nociceptive part is also there, neuropathic part is also there. Okay. Difficulties in management, so lack of awareness, I will say mainly the doctors are responsible for that. In many streams, I mean, they still believe that, okay, cancer treatment is more important than pain treatment. So even if cancer treatment fails, they just say that, okay, they understand that this patient is for palliation and not, I mean, nothing much can be done. Still, they don't send the patient to pain physician, or at least don't take care of the pain part. So this is lack of awareness. Then strict legal provisions. Most in many areas, at least in India, main important preparations are not available. Okay. Then lack of knowledge among caregivers, fear among physicians of psychological dependence and drug abuse. I never understood that why they think like that. Psychological dependence and drug abuse is applicable to a non-malignant patient. In a malignancy patient who has a limited lifespan, why we will consider about drug abuse, psychological dependence, and all? Because I have seen many in many patients. Patient relatives are more. I mean, patient is dying, but their main concern is that whether patient will become drug addict. When patient will get time to become drug addict. So these things are the problems. And lack of financial resources. A fentanyl patch is not cheap, so it is a lot of money. So lack of will to formulate national policy. So when you are treating the patients, remember two sides. One is the effect of the drug, and one is the side effect of the drug, and you have to always balance. If you target to make the pain up to zero you want to take, then there will be tremendous side effect, and patient cannot tolerate the side effect. So by making it should be optimum, side effect should be minimal. Okay, and then that's why when we make I mean, we do the pain treatment, we use multiple methods, multi-model treatment, and also multidisciplinary treatment. So in that way, you get the much less side effect with more effects. Okay. And these are also interfering conditions which tell us that which drug to give and which drug not to give. Like one patient has cardiac problem, you will not give amitriptyline like that. So treatment guidelines, treatment of cancer, aggressive treatment of pain. So mainly two main models. Okay, the one is WHO analgesic ladder and pain treatment continuum, but these two are actually same. Nearly there is no much difference. So what is that WHO treatment step? Three-step analgesic ladder. So this is for WHO analgesic ladder. I think everyone has knows what is that: mild pain, moderate pain, and severe pain. First, when the patient comes, you have to identify that patient is in mild pain, or patient is in having moderate pain or severe pain, and treatment will start according to the pain level. For mild pain, it is non-opioid and adjuvants. We can start. Adjuvants means this gabapentin, pregabalin, and your tricyclic antidepressants. With non-opioid also, you can give these things. So this is the for mild pain. When moderate, then you go for mild opioid. Mild opioid means tramadol, codeine. These are mild opioids. Then if it is not there, then you go for severe pain is very strong opioids, of course. And this is the original WHO three-step ladder. Gradually, this three-step ladder has been modified. So we go for another ladder that is called modified WHO ladder. So there in fourth step, there is interventional treatment. So if there is severe pain, we will go for interventional treatment. And as it is the patient's presentation which will dictate that where you will start. If it is severe, we will start at the intervention. But if it is mild, we will start here, moderate, we will start here, and then severe. Okay. Assessment here by history and physical examination should be at a regular interval to assess. For what we will assess? We will assess whether the patient's pain has decreased, whether patient is getting any new side effect, whether earlier side effects are decreased or not, how much patient is happy, what is the mood of the patient. So these things we will assess at every regular interval. Say we will ask the patient to come every 15 days, and that's why actually in different countries you cannot write a long term opioid and all. You can write, you can refill for 2 weeks. After 2 weeks patient or patient's relative has to come, so that you take the history again, that how is patient doing, and then you take the history. So that is what. So here, this is the modified who pain ladder. As I told you, here step 4 is also there. So pain is too much, you go for the step 4. And it is the patient's presentation from where you will start. And in treatment, there are some basic things. By the mouth, by the clock, by the ladder for the individual. Means what? Always choose oral medicine. By the clock, it is always time bound. Every 8 hourly, 12 hourly, you have to give, because that I mean, whatever the dose, how you prescribe, because if you don't give in that time, then blood level will decrease, and as soon as blood level decreases, patient's pain suddenly increases, and that we call as, what we call, anyone knows? Breakthrough pain. That we call as breakthrough pain. Okay, so say you have given 12 hourly one drug, say morphine 40 mg 12 hourly. So patient takes at 8 p.m. 8 a.m. and every day at 7 p.m. patient starts getting pain. That means you know that it is a breakthrough pain, because next dose is at 8 p.m. So you have to increase the dose. You have to make maybe 50 mg BD, like that. So that is by the clock and by the ladder. So as I told you, it is the when patient will come multiple times, and you will assess that what is the condition of pain at that point of time, at I mean, after taking how much drug. So you will decide that, okay, now this patient should get this much of pain relief. So by the ladder. And for the individual, so pain is a subjective symptom. Everyone has their different type of different sensitivity, so perception is different, so it should be individualized. I have seen many times patients, people saying that this doesn't cause that much pain, but this is very wrong. What causes pain and in which patient for what reason, that is completely subjective. Of course, you have to identify a drug addict, the which is causing due to psychological reason. He is not psychological reason, I mean, like just malingering patient. Of course you have to identify, but not every patient. So, and so I'm not going into the guidelines and all. Mainly in India, we start with morphine, and we start with 10 mg 4 hourly. So 4 hourly or 6 hourly, mainly 4 hourly we start. After stabilizing the patient with morphine, after say 15 days or after 1 month, patient will says that, okay, now my pain is all right with this much of drug. 10 mg we will start 10 mg 6 hourly, and then we'll go for 10 if patient's pain is not improving, then we'll go with the 10 mg 4 hourly, and then we'll see that how much drug patient consumes. So after the immediate release drugs are stabilized, then we will go for a sustained release drugs. We will make, say, in one day patient consumes 6 tablets, so 60, then we will make it a sustained release tablet, which will be 30 mg BID. So in this way, and then gradually you have to always try to give optimum drug, not too much, not too less. Okay, and this is also common that if you write for 4 hourly, then patient will not wake up, get up, will have to get up from bed at night while sleeping and will have to take one dose. So it is better, before sleep you can give double dose, so that that 4 hour is covered. Okay. One more. This is simple strategy. Just I told you assessment. In assessment, if you see unacceptable tolerability, then you have to reduce the dose, and insufficient efficacy, you have to increase the dose. Okay. Uh, there is a concept of opioid rotation. Opioid rotation is the treatment of opioid tolerance. Opioid tolerance means you are giving drug to some person for, say you are giving morphine 40 mg, 60 mg, 80 mg, 100 mg, 120 mg. In this way, it is going on and on and on. After some day, you will, some months actually, not day, that patient will come to you with the side effects, but pain is still not relieved. Then what will you do? Then you will do opioid rotation. What you will do, what do you mean by rotation? Rotation means by you will choose another opioid at the same equianalgesic dose. So for equianalgesic dose, these are the charts. There are multiple charts. You can keep one chart in your office so that you don't have to memorize everything. So just you rotate the drug to some other drug, equianalgesic dose, and by principle, when you are changing to another drug by opioid rotation, you make it 50% low, 50% less. Okay, so it is, if someone is getting morphine, then 300 mg, that doesn't mean immediately you will change to the, if you are say from morphine to you are going to buprenorphine or say some other drug. So you will not, or fentanyl patch and all, so you will not give the same dose. You will start from 50% and then again you will increase, because with, as I told you, opioid rotation is treatment of opioid tolerance. So then tolerance will change and patient will again start responding. And if your dose is too much, then patient can have respiratory depression and other side effects also. So guidelines for rotation, 50% reduction. Okay. Adjuvant drugs name only you see. So these are the amitriptyline, nortriptyline, duloxetine, gabapentin, pregabalin. So just for knowing purpose, these are the adjuvant drugs what we are talking about from the grade letter one. From the letter one, everywhere these adjuvants are there. Okay. So these are the side effects, you know, that all opioids has. But when you, in some patient comes and says that I cannot tolerate the side effects of opioid, then you can select the transdermal fentanyl patch. And if patient has that setup that anyone can, someone can monitor for the side effects. Don't think immediately in any patient respiratory depression comes. Always sedation come first, and then respiratory depression comes. So one rule is that if patient is sedated, always in morphine, not only for fentanyl patch, I'm saying, in fentanyl patch, of course, others have to see that patient becomes too much sedated, then they have to remove. But in other patients where you have given oral medicine, there patient has to ask for medicine, or patient has to take the medicine himself or herself. If some patient is drowsy and someone else is giving by Riles tube, or not Riles tube, sometimes by mouth also, feeding forcibly, not forcibly, I mean, if patient has not asked for it, then there is more chance of overdose. So as fentanyl patch is going transdermally, there is chance of less side effects. I'm not going in all detailed things, otherwise it will be too much time consuming. Okay, so interventions in pain management. So it has a very good one good effect is it effectively breaks the pain cycle. So this is one concept that once you break the pain cycle, so suddenly pain, if you make some patient's pain to zero for say just one day, then also again when pain comes, this because as I told you, these pains are have neuropathic pain characters. So when next time pain comes, pain doesn't reach that level, pain remains a bit less. So that is called effectively breaks pain cycle. So by intervention, when you are giving local anesthetic, then pain becomes zero. Okay, and treats peripheral sensitization. So that is what I mean. It breaking pain cycle, and it treats the sensitization mainly for neuropathic pain. Addition of ketamine and tramadol treats central sensitization, but this is ketamine means patient should get admitted. You cannot give ketamine to a OPD patient. And tramadol, of course, you can give. Tramadol has some role in central sensitization, means neuropathic pain. Okay, and diagnostic block identifies some of the pain syndromes. Now, commonly performed intervention, remember celiac plexus block, not block, actually neurolysis. Celiac plexus neurolysis. For cancer pain, it is always neurolysis. We do not do in two sessions, though in some books it is written first you go for block and see the effect and then go for neurolysis. A cancer patient, we do the neurolysis in one sitting only, and these are very effective blocks. Celiac plexus neurolysis is very effective. Remember, in upper visceral pain you will be satisfied. And then stellate ganglion block, lumbar sympathetic block, trigeminal block, so all are possible. In many patients you will be giving these injections in interventions, and of course patient gets very good relief. So never give up and keep going. So if you have any question, please ask me. Otherwise, Dr. Devjyoti will start fibromyalgia. Remember, these topics are boring, but you have to know these topics. Otherwise, you cannot practice. In my practice life also, I started practice. After 7 days, I closed that chapter, and I understood that only knowing intervention is not enough. This is 15 years back. I started after practicing for 7 days. I stopped everything and started reading, and then again I started after a few years. So this happens if you think that only knowing few injections and all are sufficient. It is not like that. So theoretical part you have to be very strong, because patient will not come with a diagnosis to you. Patient will come with a symptom, and diagnosis you have to give, treatment you have to give. So these are theoretical parts, boring, but you must know. Okay. Are you? Devjyoti?